I'm Dr. Dmitro Klokal by European Wellness Academy with title Xenogeneic Cell Therapy. Hello everyone, greetings from European Wellness Biomedical Group and its educational division, European Wellness Academy. I'm Dr. Dmitro Klokal, and topic of today's lecture presentation is Xenogeneic Cell Therapy, 100 years of clinical application. I would like to start with a quote of the German biologist August Weismann, who more than 150 years ago has determined the rationale behind the regenerative medicine in general and the stem cell therapy in particular. Death takes place because a worn-out tissue cannot forever renew itself, and because a capacity for increase by means of cell division is not everlasting but finite. Indeed, during the embryonic development, the newly formed organism is going through two major stages of development, which can be generally defined as embryonic and fetal. On the cellular level, these two stages are characterized by gradual process of cells differentiation and specialization. The process during which cells multiply, differentiate, and specialize, obtaining specific characterizations and functions in order to form tissue and organs. Basically, such developing organism is by large consisting of stem cells. Stemness is defined as the ability of a cell to perpetuate its lineage, to give rise to differentiated cells, and to interact with its environment to maintain a balance between quiescence, proliferation, and regeneration. In other words, molecular processes underline the fundamental stem cell properties of cell self-renewal and generation of differentiated daughter cells via interaction with microenvironment. The highly organized and strictly controlled signaling systems, which were established and constantly perfected throughout millions of years of evolution, regulate these two characteristics of stem cells. The self-renewal of these cells is controlled through the activation of a defined set of genes that sustain a balance between self-renewal and differentiation. Under normal physiological conditions, controlled shifts in the balance of such signaling pathways induce differentiation and maintenance of the cellular pool sufficient for the normal function of the tissue and organ. However, when abnormalities in signaling cascades occur, it can initiate and promote cellular transformation. Jumping forward, that specifically turned out to be the major limitation for the clinical application of embryonic stem cells in regenerative medicine. And similar to that, halts the clinical application of induced pluripotent cells, the iPSCs, due to inability of the engrafted cells to differentiate in vivo, even when exposed to the signaling pathways of the microenvironment that those cells are placed into. And instead, they continuously proliferate and expand the cellular volume without undergoing differentiation. On the other hand, later in life, a diminishing pool of endogenous stem cells defines the gradual loss of regenerative potential and leads to aging. I'm Dr. Dmitro Klokal by European Wellness Academy with title Xenogeneic Cell Therapy. As a classic example of this phenomenon, let's look at the cardiac regeneration potential. For many years, heart was considered to be a post-mitotic organ, which means that it has absolutely zero intrinsic regeneration mechanism. However, work of Olaf Bergmann, who did the carbon-14 study, has shown that that is not completely so. And in early years of human life, it has about 1% of the annual turnover of the cardiac myocytes, which later in life becomes as low as 0.45% per year. Taking into consideration that a single myocardial infarction event may result or can be associated with the death of nearly 1 billion of cardiac myocytes, makes it essentially impossible to recover and regenerate the affected myocardium without development of the cardiomyopathy. That is clearly demonstrated by the statistics from the survivors after acute myocardial infarction in Europe since 1980s, analysis of which shows that particularly all non-fatal myocardial infarctions end up as patients with chronic cardiomyopathy, which in its turn has almost 50% 5-year mortality if not treated by either heart transplant or left ventricular assist device, or at least partially managed by one of the 3 existing pharmacological options, either inotropes or vasodilators or beta blockers. So let us look at the adequate therapeutic goals of cardiac regenerations. I say adequate meaning sufficient to restore, at least to some extent, the function of the affected zone of myocardium. The effective cardiac regeneration implies the new myocyte formation at the affected area of the myocardium. Secondly, those newly created myocytes must be mechanically and electronically coupled and integrated into the tissue. They should replace the scar tissue. And last but not the least, there must be a sufficient blood supply restored to the newly regenerated tissue. The process called neovascularization or revascularization. Otherwise, the cells in the anatomical area they were attempting to regenerate will not be able to survive. Currently, there are following ways of cell-based cardiac regeneration. Bone marrow cells of various cell types, including hematopoietic stem cells, mesenchymal stem cells, and endothelial progenitor cells. These types of stem cell transplant are considered safe to use as a treatment to improve post-myocardial infarction hearts in humans. They improve angiogenesis, left ventricular function, and cardiac muscle perfusion, and also capable of reduction of mortality somewhere between 7 to 15%. However, in vivo studies did not observe the engraftment of the MSCs in the infarcted hearts several weeks after acute MI, and survival of the engrafted MSCs was only about 2% or less, with no evidence of cardiomyocyte differentiation in these cells. Currently, most MSCs described in the in vivo studies report that the engrafted MSCs die within 2 weeks of transplantation with little or no direct cardiac differentiation. So the clinical efficacy is mostly attributed to rather paracrine factors, the cytokines and growth factors, which are stimulating cardiomyocyte proliferation and neovascularization of the infarcted areas, resulting in myocardial regeneration of a very mild degree. Next one are the cardiosphere-derived cells, CDCs. Those are the cells isolated from myocardial biopsy specimens of patients undergoing heart surgery. The heart fragments from these biopsies are cultured on fibronectin-coated Petri plates. After a few days in culture, the biopsied heart cells form into a monolayer. These cells appear to be of cardiogenic lineages and can be retrieved by enzymatic treatment, followed by replating on cultured dishes using cardiac growth medium. Cardiac-derived cells appear to be able to integrate into the heart wall and end up in the infarct zone. At about 3 weeks post-injection, the healthy living myocardium in the infarct zone is significantly larger in the CDC-treated hearts. However, the procedure is quite invasive and it's time-consuming, plus the cellular material is quite limited. Lastly, hence the molecular mechanisms of cardiomyocyte differentiation remain unknown. Thus approaches used for differentiation of embryonic stem cells or the iPSCs is not clear as well. That puts these cell-based strategies far from clinical application on a wide scale. Remarkably, the most of the predicaments mentioned above can be avoided with the fetal precursor stem cells, which, apart from the paracrine effect and vascular neogenesis, also produce direct homing effect and ability to retain in the myocardium up to 20%. Such properties of fetal precursor stem cells result in downstaging of the functional class of the heart failure observed in majority of the patients within 6 months, increase of the ejection fraction on the average between 13.5 to 20%, and relatively lasting effects up to 2 years post-administration of this type of cells.